trained clinicians program. In the second years, we have EBG, that is evidence-based gastroenterology. And third year, we have one more program called the GYM. These three programs are being organized by ISG state, not the state, the national body is going to conduct this program. So the candidates have been selected by the concerned HODs and professors of their institutes. So the point here is that the learning curve, of course, we regularly have a learning curve throughout our life, but we'll, as HOD or professor, they will select the candidates and they will send it to these EBG meetings or YCP meetings, whatever. YCP is mainly focused on the research methodology, how you are going to do your thesis for all these things. Second year is this EBG, how all clinical students who are experts in their field, they will be called and they will be given talks. And GYM is specifically meant for the exam going, outgoing. So how a long case could be, how a short case is, how are you going to face this ward rounds and then instruments and reset advances, all those things. So at this juncture, I have to inform you to keep in your mind. And last time also I told, we all should feel proud that we have taken gastroenterology, one of the most upcoming, advanced, recent innovations. So many things are happening. Even if you look at the recent newspaper, all gastroenterology seats have been filled up. Not even one seat left over in entire India. Whereas cardiology and other specialties, many are vacant. So with these few words, I request the Apollo people and the Sharda and everyone to conduct the proceedings.
We have a slight change in the order of the cases here.
Jatin Egula, consultant gastroenterology at Apollo Hospital. So the second case also revolves around portal vein. So we have an international patient that came to us. It's a 18-year-old female patient with main complaint of dyspnea on exertion for the last 4 years associated with easy fatigability, but she did not have any platypnea. On probing, she also gave history of altered sensorium episodes, 1 to 2 episodes per year. Each episode used to last for 15 minutes to 1 hour, and it was conservatively managed, and they did not really seek healthcare. And she also reported altered sleep rhythm and daytime sleepiness, leading to poor scholastic performance. And on examination in the clinic, she had markedly elevated JVP, and she had a parasternal heave with parasternal murmur. The CNS examination and per-abdominal examination were unremarkable. Even she did not have astraxis. So with the investigation that she already had with severe fatigability and dyspnea, we expected that she would be having some anemia, but surprisingly her hemoglobin was very good. LFT showed only mildly elevated transaminases, and with an albumin of 3.1 and platelet count of 2,20,000. For the altered sensorium episodes, for metabolic point of view, she was evaluated with by the neurologist with MRI, brain, EEG, and all the metabolic parameters including renal functions, electrolytes, TSH, and HbA1c were normal. And chest X-ray showed cardiomegaly, and ultrasound abdomen, it was reported as altered ecotexture. And basically, the patient went to the cardiologist for dyspnea, and cardiologist referred the patient to us for deranged liver enzymes and altered liver ecotexture. So initially we ordered autoimmune markers, it was negative, AFP was normal, and on probing she gave history of recurrent HE episodes, so we did an ammonia that came out to be elevated. So we were suspecting that patient would have CLD and she must be having HE. But the FibroScan values, the LSM was normal. Meanwhile, the cardiac evaluation, patient had dilated RA, RV with severe tricuspid regurgitation and severe pulmonary artery hypertension. LV ejection fraction was normal. So, in the background of liver disease and pulmonary and dyspnea, contrast echo was also done, which showed no evidence of hepatopulmonary syndrome or intrapulmonary vascular malformations. This is the CT pulmonary angiography done by the cardiologist to look for the cause of such severe pulmonary artery hypertension. This again showed similar findings of dilated right chambers with hugely dilated pulmonary artery. Here it is. So, and there was no evidence of pulmonary thromboembolism even in the subsegmental branches, and incidentally they found an abnormal venous communication between the portal vein and the IVC, and this was ignored by the cardiologist, and when we took the history and when we were planning for liver disease workup, then we found that this was already reported in the CT, and we performed a triphasic CT to correctly understand the anatomy. And here you can see that the liver outline is normal, there were no liver nodules, and here this is the portal vein communicating directly into the IVC, and there are no intrahepatic portal venous branches seen. So if we summarize, here we have a very young girl, 18-year-old, who's coming with recurrent HE and severe pulmonary arterial hypertension and extrahepatic portosystemic communication without liver cirrhosis. We diagnosed the patient as having Abernathy malformation, and that was responsible for her HE because the mesenteric blood flow is being shunted to the IVC, bypassing the first pass metabolism. So there are a lot of amines and vasoactive peptides that are going into systemic circulation that can cause pulmonary vasoconstriction and pulmonary arterial hypertension. Also the sheer hemodynamic volume that is being diverted into the IVC can cause pressure on the right atrium, right side of the heart. So now how do we manage this patient? She was already on rifaximin and lactulose. She is already on sildenafil and ambrisentan by the cardiologist. So should we just continue the conservative management, or should we attempt to close the shunt? And if we have to close the shunt, should we close the shunt, or should we subject the patient to liver transplantation? Because there were no intrahepatic portal vein radicals, and eventually it is going to progress. So, and if we are choosing shunt closure, should we do intervention guided closure, or should we subject her to surgical management? So these are the questions that were there at this point of time. So before we tell you what we did with this patient, let's discuss Abernathy and then we go back to the case. So Abernathy malformation, it was first described in 1793, and it is basically shunting of the portal blood into the systemic circulation, partially or completely. If you look at the types, this is very important. This underlies the management strategy, whether the patient has a type 1 malformation or a type 2. So the only difference is whether the intrahepatic portal vein branches are there or not. So in type 1, the intrahepatic portal branches are not there, and the splenic vein and superior mesenteric vein join directly into the IVC without forming a common channel. This is 1A, and if they form the common channel and directly join, this is a end-to side anastomosis, and this is type 1B. So these two are type 1, and these patients have to be subjected to liver transplantation. And the person who has a side-to-side shunt is type 2 malformation, and these are the ones who we can try shunt closure. So most of the studies, most of the literature is restricted to case reports, but the largest series is including 66 patients, and it was an international retrospective study spanning around 30 years almost, and this also included data from 3 of our Indian centers. So if we look at the data of this study, so we can see that the median age of presentation is around 20 years, and there was no gender preponderance overall, and this is the data of 66 patients that was published in nephrology. So type 1 malformation was seen in 60% of the patients, and type 2 was in 40% of the patients, and most of the times these patients do well, especially the type 2. Only they have episodes of altered behavior, and they come for various other reasons, and they get detected with extrahepatic portosystemic shunt. So 20% of the patients who were diagnosed with Abernathy came with symptoms of sepsis, congenital extrahepatic portosystemic shunt. So among them, 10% of the patients came with recurrent or persistent HE, and 10% of the patients came with dyspnea. Now the dyspnea in these patients could be because of two reasons. One is hepatopulmonary syndrome because of pulmonary vasodilatation, or second is because of pulmonary hypertension. Among these patients, deranged elevated transaminases was observed in 25%, as was observed in our patient. Now if we look at both the types separately, so type 1 is the one which is more severe because hardly any blood was going to the liver. They are going to present very early in the age, early. There is a female preponderance, and there is also associated congenital anomalies, mainly cardiac anomalies, and these are the ones who are more likely to present in the first decade or around 10 to 15 years. In contrast, our patient was type 2, and she presented at the age of 18, and there were intrahepatic portal vein radicals that were detected after balloon angiography that I will be discussing later. Coming to complications, as I said, hepatic encephalopathy, portal pulmonary hypertension, hepatopulmonary syndrome, and HCC in these patients is also described. However, with very atypical findings, and the classical enhancement patterns may not be seen because of vascular perfusion abnormalities. So the threshold for biopsy in these patients when you have a liver nodule should be very low. So these patients, these 16 patients, they are followed up for almost median follow-up of 4 to 5 years, and what they noticed is that 25% of the patients eventually developed HE, although only 10% presented with HE. So subsequently there is a risk that they might develop HE even if they are asymptomatic now. So 40% of the patients had liver nodules, most of them were FNH or regenerative nodular hyperplasia, and 20% of them were HCC. Most of the HCCs were in type 1. Pulmonary complications, as I discussed, because of the vasoactive mediators bypassing the liver and the hemodynamic load. So how do we manage these patients? Any patient who is having Abernathy malformation, who are symptomatic with encephalopathy or liver dysfunction, or even asymptomatic patients who have a shunt ratio more than 60, these are the ones who we are supposed to offer them definitive management. This was suggested by some of the people who have published the cases, and these are not societal recommendations. And all the type 1 patients, type 1 shunt should be subjected to liver transplantation, and type 2 should be subjected to shunt closure. If we go into the details, how do we plan the treatment? So the symptomatic patients, so we have to perform a balloon occlusion test to see whether the intrahepatic portal vein radicals are actually hypoplastic or they were just concealed because of low flow. So once we do the balloon occlusion of the shunt and then do the contrast study, then we will be able to see the intrahepatic portal vein radicals, and we also measure the portal vein pressure. If it is very high, then suddenly blocking the shunt may not be a good option, and people have suggested that we have to do a partial closure initially, and then subsequently when the portal pressure is slowly come down, we can do a repeat procedure later on. So for those with pressure more than 32, they have suggested a 2-step closure. For those with less than 32, 1-step closure. Asymptomatic patients should we really treat? So this was a big question, but people have suggested that somebody who is having a shunt ratio more than 60%. Shunt ratio is the amount of blood that is diverting into the IVC compared to the one that is going into the liver. So if it is more than 60%, people have suggested that they are supposed to be treated. So coming back to our case, this is the DSA image, DSA video. Here you are able to see that this catheter was passed from the IVC into the portal vein through the shunt. And once the contrast, you are able to see this is the portal vein inferior mesenteric, superior mesenteric forms the portal vein, and the contrast is going into the IVC. Here, this is the shunt. So next what we did was we did with the help of the intervention radiology colleagues, we have performed a balloon occlusion test before planning the intervention. And here in the shunt, the balloon occlusion was done, and this another catheter passed from the femoral side has measured the pressure, as we discussed whether we should go for a single stage closure or a double stage closure. So pressure was 20 millimeters, and we decided that this is the patient who is going to benefit from single stage shunt closure. However, the challenge was that the shunt size was very big. It was around 24 millimeters. Most of the published literature showed size of around 10 to 20 millimeters, and they used vascular plugs. But no vascular plug could fit into this size. So it was a challenging thing. So we discussed with some of our seniors in IMS and intervention radiology seniors and faculty, and then they have suggested that we should go for an ASD device closure, and that is what we have done here. You can see that the ASD closure device is being deployed in the portal vein, the shunt between the portal vein and IVC. So here, this is the ASD closure device successfully deployed in the shunt, and after that the color Doppler showed no flow across the shunt. So this plain CT that we have repeated after the procedure, you are able to see that the shunt, the device is completely blocking the shunt. So since the literature has suggested that after placing the shunt there is high risk of thrombosis of the superior mesenteric vein or portal vein because of the device, we decided to give them short course of anticoagulation for 3 months, and we've stopped the anticoagulation after 3 months. Her dyspnea has improved, her fatigue has improved, and patient did not have any episodes of HE since then. 3 months after follow-up, we got the echo done and arterial ammonia. Ammonia was normalized, and echo showed no pulmonary arterial hypertension, and she only had few changes of previous pulmonary hypertension like dilated pulmonary artery and pulmonary valve prolapse. So she is due to come back. She is a resident of Kenya. She is due to come back next month, and we are going to plan another echo and CT abdomen to document the 6 months follow-up. So highlights of the case is that patient is presented with severe pulmonary arterial hypertension and dyspnea. The shunt size was very large. However, we had ASD closure device to our rescue. So take-home messages: any patient who is young and coming with recurrent episodes of HE and there is no cirrhosis, suspect extrahepatic portosystemic shunt. In case of type 1 shunts, search for other structural abnormalities. And in order to differentiate between type 1 and type 2, imaging is not sufficient, and you have to do a balloon occlusion angiography to confirm differentiate between type 1 and also to measure the pressure to plan the therapy. To summarize the treatment, asymptomatic patients who has a shunt fraction of less than 40%, we can safely follow them up, and patients with type 1 liver transplant, type 2 shunt closure. Thank you.
Develop more collaterals because of this.
Sir, the collaterals, basically the shunt is going to divert the blood flow to it. There are intrahepatic portal vein radicals and they are going to open up.
Fair enough. Now, what is the life of this particular shunt?
It's going to be lifelong implant.
Fine.
If you look at ASD and PSD, when there is a severe pulmonary hypertension, they don't put these stents, stating that lung function is not going to improve. But here, it appears to be reverse. See, patient already had severe pulmonary artery hypertension. Despite that, you had placed that device closure here.
So
Pathophysiology is same, whether it is ASD or VSD.
but here we are reducing the load to the cardiac inflow. So we are basically blocking the flow and reducing the and the right side of the heart and the pulmonary.
So the
But in
preload
ASD
is-
also same mechanism is there. There is severe pulmonary artery hypertension. They don't place these closure devices stating that lung is not going to improve by placing these devices.
And also, once the Eisenmengers, so once the Eisenmengers are set in, the shunt,
No, there
the
is-
flow is from the right to
Dr.
left.
Srinivas, there is a parenchymal interface, no? So it's a gated reduction in the gradient, so it would help. Yeah. Whereas in VSD ASD, there is a direct pressure impact. Here it's a indirect one, no? So it would help.
Is she off her pulmonary hypertension medication?
Yes, she's off her medication. She's off all medications.
What would be the reason for pulmonary hypertension? Is it the vasoconstrictors? Is it the vasoconstrictor mechanism, or what's
It is
happening
increased
exactly?
preload.
What
I
might
think it
have
is both
caused?
the hemodynamic overload, chronic hemodynamic overload, the sheer amount of volume that is on the right ventricular pressure, and also the theory that is that vasoactive separates can cause vasoconstriction, and probably that these two mechanisms.
I think it's a very good case. I mean, very interesting, and we don't see much of this at all. But sometimes we do see patients who have high ammonia, who develop some encephalopathy. Nothing is really diagnosed in them. Going around as urea cycle enzyme defects. We don't do these testings. So I think in that situation, I think we should try and do this angiography and try to find out a bigger shunt and evaluate this disease.
And sometimes we do get reference from neurologists saying that the ammonia is high and they're not able to find the cause. Sometimes they are on valproate and we attribute it to it. But if they are off medication, then we should really consider whether this patient is having this, especially in the younger group.
These referrals from neurology department is always there
Yes.
with high ammonia.
When we look at the natural history in the long run, is there liver cell failure?
So patients did have, especially in the type 1 patient, by the time they reach second decade, because hardly any blood is going into the liver, so they develop complications of liver cirrhosis and they develop HCCs, and most of them don't survive without liver transplantation, especially type 1. Type 2 there is some amount of blood flow, but in our case, the shunt fraction was more than 90%. Eventually, the fraction is going to be increased, and she is going to develop if we don't treat. Even the published literature also said that if we don't treat, they are going to develop complications of cirrhosis.
But are they more likely to develop cardiac cirrhosis than
So,
reduced portal inflow?
our patient was having pulmonary hypertension, but the previous patients that I managed back in AIMS, all of them had only recurrent HE and they didn't have any pulmonary hypertension. So this was unique because this presentation with pulmonary hypertension and this thing HE, it was unique. So probably because of the reduced blood flow to the liver is going to get cirrhosed. That is the main mechanism. Thank you.
Is a portal vein tumor. Can we put a needle? I think we are all very curious to know why we would want to put a needle. So because the indications are very, very few. So we are equally curious to know the indication and the technique as well. I'll ask Dr. Vijay to make a start.
Good evening, everyone. Let us start with the first case. Tumoral portal vein thrombosis. Can we put a needle? Coming to the case, he is a 66-year-old gentleman who is a known case of NASH-related CLD. He was diagnosed in 2007 and he had index decompensation with ascites, which was diuretic responsive in 2022. And there is no history of GI plate, and his last upper GI endoscopy was done in May 2023, which showed small esophageal varices. And there is no history of hepatic encephalopathy or AKI, and viral screening is negative for hepatitis B and C. So he presented with significant weight loss, which is about 12 kg in 6 months, and his laboratory workup is hemogram showed mild anemia, HB is 11.2, platelets were normal, and LFT showed mild transaminitis with AST 62 and ALT 42. So his coagulation parameters, his INR is 1.4, and his other parameters, renal profile like serum creatinine is 1.2, sodium 131, and his MELD sodium score is 90 with CDP-B status. And he has markedly elevated tumor markers such as AFP, which is 4805 nanogram per ml, and PVTT, which is 1800 milliabsorption unit per liter. So, upper GI endoscopy was done, which showed 4 columns of large esophageal varices, for which EBL was done. So, in view of markedly elevated tumor markers, ECT abdomen was done, which showed liver which is normal in size with heterogeneous attenuation and irregular outlines suggestive of chronic liver parenchymal changes. But there are hypodense contents noted within the main portal vein and porta, causing mild expansion of the portal vein of about 17 mm, and which is extending into the right, left portal vein and its branches, which are recanalized by collaterals, suggestive of chronic portal vein thrombosis. And there is no evidence of hypervascularity noted within the hypodense contents. And multiple collaterals noted in periportal, gastrohepatic regions, and prominent submucosal vessels in the esophagus. This is a portal base MRI abdomen showing so extensive non-enhancing and non-hypervascular thrombosis involving the right portal vein, which is main portal vein, which is extending into the left portal veins, and its branches supplying 5, 6, 7, 8 segments. And in this arterial phase, we can see that portal vein thrombus is not enhancing. And there is no definitive liver mass lesion. So this is a Doppler imaging showing no signal intensity, no color Doppler signal intensity in the main portal vein, suggestive of blunt thrombus. So what is the next summary? This is the patient of decompensated liver disease with significant weight loss, elevated AFP and PVTT with no obvious liver SOL in cross-sectional imaging studies, and blunt portal vein thrombosis. So what are the possible options? Whether to anticoagulate or go for a liver transplant or start an immunotherapy. So as the portal vein thrombosis is a chronic portal vein thrombosis, anticoagulation is not an option, and for liver transplantation, markedly elevated AFP and PVTT suggest highly suspicious of hepatocellular carcinoma. So if there is a tumor portal vein thrombosis, it stages as BCLCC and we cannot go for a liver transplant. And immunotherapy, Without a tissue diagnosis, we cannot start off with immunotherapy. So before going into the main thing, let us get some insight into the bland thrombus versus tumor thrombosis of portal vein and its differences in the imaging studies. Before that, the main mechanisms causing portal vein thrombosis are due to disturbance in any element of the virtual triad, such as stasis, endothelial injury, hypercoagulability. Some of the causes are cirrhosis, intraabdominal malignancies like pancreatic carcinoma, gastric carcinoma, hepatocellular carcinoma, cholangiocarcinoma, and extensive compression by lymph node or tumor. Endothelial injuries occur in many inflammatory conditions such as acute pancreatitis, cholangitis, sepsis, appendicitis, TB lymphadenitis, diverticulitis, etc. And hypercoagulability states, we all know, inherited conditions like protein C, S deficiencies, antithrombin 3 deficiency, factor V Leiden mutation, and acquired conditions such as APLA, PNH, myeloproliferative disorders, hyperhomocystinemia, and genetic mutations such as prothrombin gene mutation and MTHF reductase mutations, and systemic conditions such as HIV, Behçet's, and celiac. So, actually, portal vein thrombosis is an ultrasound finding in up to 8% of liver cirrhosis patients. Generally, we can see that. But once hepatocellular develops, the risk of portal vein rises to 40%, and some studies show it even rises to 70%. So, malignant portal vein thrombosis is an important determinant of tumor staging as well as prognosis and influences treatment selections. And it indicates poor prognosis and is an absolute contraindication of liver transplantation because of unavoidable tumor recurrence. Benign portal vein thrombosis can also occur in liver cirrhosis, and the hesitation to treat it may negatively affect a patient prognosis. So when a patient of portal vein thrombosis comes, we need to exclude pseudothrombosis and imaging artifacts like Doppler settings, low velocities, depth of the vessel, and Doppler angle of insinuation may cause pseudothrombosis. After that, to confirm, we can proceed with Doppler ultrasound, contrast enhanced CT and MRI, and tumor markers such as AFP and PVTT. So basic differences is the table showing malignant portal vein thrombosis and benign portal vein thrombosis differences. There is pulsatile pattern in Doppler, and the CT shows contrast enhancement at arterial phase. It should show neovascularity within the portal vein thrombosis, and portal vein thrombus diameter is usually greater than 23 mm, and there may be a visible hypervascular tumor in close proximity to PVT. In benign portal vein thrombosis, there will be no pulsation, non-enhancement on arterial phase, and portal vein diameter does not exceed 20 mm. So our case has all these findings. There is no pulsation in Doppler, not enhanced in arterial phase, and portal vein diameter is 17 mm. So as already said, as per the imaging study, patient has a bland portal vein thrombosis. So should we put in a needle for this FNA because there is no SOL, elevated tumor markers, and highly suspicious of hepatocellular carcinoma, but imaging studies are still showing bland portal vein thrombosis. So if S, which is safer, percutaneous ultrasound guided or endoscopic ultrasound? So before why to put a needle? So portal vein thrombus does not always demonstrate neovascularity, and these reasons could be attributed to non-classical enhancement because of immature vascularization in the early HCC. And microvessels may be compressed by fibromatous change originating from HCC formation. Therefore, it was thought that portal vein tumor thrombosis was not enhanced from arterial phase to portal phase by CT scan. And the decisions to sample a portal vein thrombosis becomes vital when there is no discrete or infiltrating liver mass, non-diagnostic increase in AFP level, and equivocal intensification of the tumor thrombosis. So comparing the methods, percutaneous ultrasound guided FNA or EUS FNA. Drawbacks of ultrasound are difficult in obese patients and in moderate to gross ascites patients, and there is high risk of biliary tract on arteriovenous injuries, and there is difficulty of sampling a thrombus located in the central main portal vein, and relative increased risk of peritoneal carcinomatosis due to needle tract settling. And these risks are minimized by endoscopic ultrasound, as there are less risk of biliary tract injuries, and FNA needle can be positioned directly into the PVT, and there is low risk of peritoneal carcinomatosis. And the new entity called contrast enhanced EUS further enhances diagnosing focal liver lesions, which are missed in CT or MRI, and they have better tissue sampling. Few points regarding contrast enhanced EUS. Contrast enhanced EUS increases the detection of focal liver lesions from 73 to 93%, and various contrast patterns reported in the literature of focal liver lesions after contrast enhanced EUS are non-enhancement and hypo-enhancement in case of metastasis, pancreatic CA and GBCA, iso-enhancement in metastasis, and hyper-enhancement can be seen in HCC, neuroendocrine tumor and metastasis. So mainly the contrast enhanced endoscopic ultrasound helps to identify the hyperperfused area that needs to be targeted and the avascular area suggestive of necrosis which needs to be avoided while sampling. And another advantage is that contrast enhanced EUS helps in reducing the number of passes as compared to conventional EUS. A study from Okatsa et al. Showed that CT and MRI missed focal lesions in 58 patients, 42 of which are metastasis though, which were subsequently detected by contrast enhanced EUS. So after that, we proceeded with EUS FNB of the portal vein thrombosis. This is showing portal vein thrombosis from D1 with surrounding collateral vessel formation, and using a 25 gauge needle, 2 passes were made and tissues were sent for cell block and cytology. So this is already explained. On-site pathological examination revealed malignancy. This HV slide showing sheets of neoplastic cells arranged in clusters and seeds, and clot sections showing viable tumor cells with marked anisonucleosis, and there is necrosis in some clot sections. So immunohistochemistry was done for HEPA, highlighting the tumor cells here and here. Other IHC markers for hepatocellular carcinoma include c-KIT, glypican-3 and AFP. So after that he was started on immunotherapy, 2 doses were taken till now. After 3 months he had a GI bleed, EVL was done elsewhere, but repeat CT abdomen showed no liver SOL and still suggestive of bland portal vein thrombus. And 2 slides regarding another case. After 15 days we got another case, similar thing. 8-year-old with a known case of CLD as related with elevated AFP, no liver SOL and equivocal intensification of main portal vein thrombosis. This showing same thing, portal vein thrombosis with no new vascularity within it. And EUS FNB again was done. This time pathological exam again revealed atypical hepatocytes with large nuclei and intranuclear inclusions, suggestive of HCC. And focal cytoplasmic brownish pigment suggestive of bile can be seen here and in some parts of it. So after that, he deteriorated rapidly with grade 4 encephalopathy and MOTS leading to his death. So this is the first case report published in 2013 with the portal venous tumor growth type of hepatocellular carcinoma without liver parenchyma tumor nodules. So for take-home messages, not every portal vein thrombosis in a patient with HCC is a tumor thrombosis. Nature of the thrombus will ultimately determine the course of treatment, and so every effort should be made to distinguish between a tumor and non-tumor portal vein thrombus. And portal vein tumor thrombus does not always demonstrate neovascularity. I already said the reasons, because of microvessel formation in early HCC, which makes FNA of the portal vein thrombosis really necessary. EUS guided of a portal vein thrombosis when present is a safe and effective procedure for diagnosing and staging HCC. Because 30% of the patients have normal AFP levels and they usually remain low even with advanced HCC. HCC only in the portal vein without liver parenchyma tuber nodules, so is always a possibility that should be kept in mind. And finally, getting a tissue diagnosis in a patient awaiting liver transplantation is vital. Thank you.
Thank you, Dr. Vijay. 2 good cases. Interesting, both did not have liver lesions, only had portal vein. I had a couple of questions for you. First one, the portal vein diameter you mentioned, 17 and 20. Is that, I'm sorry, 20 and 23. Are they absolute cutoffs to think of bland versus tumoral thrombosis? Or did one paper randomly
No,
suggest?
randomly it's paper. There is no.
I don't think it should be absolute.
It's not absolute.
Yeah, we should not think of that. Number 2, was there a uniform dilatation of the portal vein or was it a sudden expansion of the portal vein? I think that also hints towards tumoral portal vein thrombosis. Number 3, the choice of CT, MRI as the first investigation rather than a CT.
No, we did CT first.
CT also was done.
Yeah, first I said the CT findings, but the imaging studies were not available, so I just read the findings.
Okay. So wanted a second modality also
Yeah.
to look for a
Yes, well, liver as
tumor
well.
within the liver. My final question. Was a PET CT considered and were there any contraindications?
Yeah, in some studies, no ma'am. PET CT is possible, which can show little high SUV uptake in tumor thrombosis. It can be considered as a second modality of choice.
I think it
In
should
some
be
studies,
considered.
yes.
Yeah.
In some
Especially
reports,
when
they
you
did
do not
PET
have-
CT instead of MRI. The initial modality they did CT, and other modality second they went for PET CT.
Yeah, I think if the CT or the MRI only shows portal vein and the contention is between the gland as well and tumoral thrombosis, I think a PET CT is a reasonable non-invasive investigation, is my opinion.
PET CT pickup in HCC is little poor, so probably that is the reason it is not.
Because the opinion of the oncologist.
And second case which had some complicated reasons, was it intervention related complication?
Markers for immunotherapy. So they were not having PET, and then he came to us for tissue diagnosis. So whether we should do or not, then the question of FNA came. So there were some problems with the FNA. So what needed to use, whether 22 or 25 or FNB, because we want to get a good tissue. We want to do ISA as well. So some people may prefer to do an FNB needle one pass around with an on-site pathologist in place. Because we need a tissue diagnosis accuracy or not, because we can repeat this procedure again. In first patient had some polyps around the portal vein. So we had to, actually I thought of not doing the procedure. Then we had a window where between two collaterals we could, I thought that we can safely pass inside. So the another problem is there is no enhancement in IV contrast in CT or MRI. So I don't know which area I should sample, and the representativeness of the sample is also important. So what I thought was the most expansive part of the thrombus, suddenly when the caliber has changed.
Transplant. So do we need to do an effort to do that? If the option for transplant is not there, yeah, aggressive approach is very good, because as you said, survival rate probably partially increases. I mean, this is just a discussion. You don't need anything. You don't need anything, because anyway, even if it is a tumor thrombus, they would like to sincerely attempt. Maybe higher centers, because when we send this, it all depends on the center. I was speaking to Professor Rela, and he says he's very aggressive. He says we do it, no problem. They reconstruct the portal vein. No, it's okay. I mean, I agree with you that as Madam said. Yeah. Even there is an isolated, only right portal vein or a left portal vein thrombus alone can be there, and that can also be a tumor. You don't have to have a main segment thrombus.
I think I just wanted to add what I was about to tell. I think Sethu sir was mentioning it. But I think if I remember the ASLD guidelines correctly, I think the dilemma is only when the size of the lesion is less than 1 centimeter and your AFP is less than 200. Otherwise, for all practical purposes, I think elevated AFP and PVK is more than 90%. We are sure it is probably HCC. But I think, and the other thing was that probably you can also safely use a 22 gauge needle.
What is the evidence to suggest to 22 or 21?
Good evening, everyone. I'm Dr. Rohit, final year DMP resident from Apollo Hospitals. I'm here to present a case, unusual finding in colonic polyposis. A 48-year male, no comorbidities, resident of Mozambique, East Africa, presented to the OPD with the complaints of lower abdominal pain, constipation, and occasional bleeding PR for the past 6 months. So no issue of any fever, vomiting, or anorexia and weight loss. On initial evaluation, he was found to have mild microcytic anemia, normal platelets. His liver function and renal functions are normal. Incidentally, he was found to be HBsAg positive, though the viral load is not detected. Ultrasound does not show any features of CLD or portal hypertension. As the patient has chronic symptoms of abdominal pain, bleeding PR and constipation, we did a colonoscopy, and the colonoscopy image shows large number of multiple sessile and pedunculated polyps. And just show you. Yeah. So multiple sessile pedunculated broad-based polyps starting from around 15 centimeters of the anal bulge, and there are also areas of isolated polyps, and these polyps on NBI imaging, these polyps showed inflammatory type of polyps with the surrounding mucosa showing normal vascularity. There is no evidence of any ulceration in the surrounding mucosa. So we took multiple biopsies from the polyps, and this is what. So any thoughts here? So this is the NBI image of the polyps we found. So the polyps were showing inflammatory type of polyps, and surrounding mucosa does not show any ulceration and normal vascularity. So any thoughts?
What's the family history?
No family history of any colorectal cancers.
You read the genetics.
No.
So they were not screened, they were not subjected to the Yeah, but so we can't say, as of now, we can't say, because ideally you suggest the family screening at least.
So, to our surprise, the biopsy report came out to be an egg with a terminal spine and showing lot of dense eosinophilic infiltrate surrounding the egg, and finally the patient was diagnosed as schistosomal polyposis, parasitic disease. So HPE showed aggregates of O of schistosoma showing a terminal spine and a ill-defined histiocytic reaction with a dense eosinophilic infiltrate around the parasitic ova with chronic inflammation suggesting fibrosis of lamina propria. There is no evidence of any malignancy. Next, we treated the patient with praziquantel antihelminthic 60 mg per kg single dose stat given in 2 to 3 divided doses on the same day. We repeated the similar dose after 4 weeks. So he was reviewed in the OPD after 6 weeks. Patient had resolution of symptoms, no pain abdomen, constipation was better with laxatives, no further bleeding PR. We just repeated a sigmoidoscopy to look for any resolution of the polyps. There was hardly any resolution or regression of the polyps, it remained the same. So we again took repeat biopsies. It again showed calcified eggs with features consistent with schistosomiasis and fibrosis of lamina propria. So in some of the case reports, it also said the polyps can be there in the duodenum and sometimes also the gastric polyps. So we did an endoscopy which was normal. There are no features of any portal hypertension also. So what next? Will further doses of praziquantel help in the regression of polyps? Is there any confirmatory test to say that patient got cleared of the infection? Does he require any further surveillance for the colonic polyposis? Is endoscopic or surgical removal indicated for all the polyps?
Can I ask you a question?
Sir.
Incidental or the disease itself is primary? It's a sort of infection. Why do you want to give so much of stress? You have something in your mind. For example,
Yes.
Why are you stressing so much on present? It's okay. You treat it, it's persistent, it is resistant. But your polyps are still issue.
Yes.
You're always worried about this.
But
your approach would be reasonably surgical rather than playing with you. I don't know how you're going to approach it.
Inflammatory polyp by surgery.
You want to say it is inflammation.
Julie, figures, you need to characterize the polyps, okay? The colonoscopic picture is not typical of polyposis syndrome. It is not typical of attenuated polyposis. There is no microadenomas all over the polyps, and your characterization in NBI shows that they are not true polyps, okay? So you classified them as a inflammatory polyps category. Less than 1% can be malignant if there is a chronic inflammation on the long run. Particularly the malignancy incidence is more in the upper GI tract than the lower GI tract. Lower GI tract, the main side effects will be the chronic anemia and pain if it is in the lower part of the rectum and sigmoid area. So we should not get confused with colonic polyposis, familial adenomatous polyposis for this one, because they are not true polyps. So it doesn't need surveillance, long-term surveillance. It can be resected endoscopically if it is causing any problem, very safely, without any problem. But you need to, if it is all in the sigmoid, left hemicolectomy is a simple process, but doesn't need, I think.
These 4 points have to be answered. You are the polyp specialist, no?
Yes, sir. Praziquantel is the first line of treatment. Oxamniquin is the upcoming drug. It's a second line drug, still in the clinical trials. But as of now, the only treatment is praziquantel. Periportal areas, pre-sinusoidal areas of the liver cause fibrosis there and can develop portal hypertension in the future. There is always a risk.
So it can cause, but why is the question now? We have such a big question, we can do a liver biopsy and find out what exactly is happening now. You see the liver fibrosis.
No, how is it going to change the management?
It's not going to change, but the question is going up now. In future, it could, but how is it a question now?
Normally in the literature they said that if there is an adult worm and then we treat it with this thing, then we are going to kill the adult worms, but the eggs we are not able to kill with the drug. So the eggs are going to be there, and the inflammation that has already happened has happened. We cannot regress the inflammation. So after discussing with the infectious disease team, we decided not to treat with further doses. We had this doubt that whether in future there is a minuscule risk of malignant transformation or patient developing portal hypertension, and we had a multidisciplinary meeting and we thought that we would give the option to the patient, and we gave the option of undergoing left hemicolectomy, but the patient was not very keen on undergoing surgery because the symptoms have resolved and he wants to be under follow-up. For the fear of the portal hypertension or malignancy, or he doesn't.
Can you explain what is calcification? Is it calcification?
I think just after it is, I don't know, it's just dystrophic calcification. After death of the tissues, this calcium getting deposited.
Is it the 4 week back to see if there are new, like the eggs have hatched and new worms have come, and so you get them the second time?
I don't know.
May we ask one question to you?
Yes.
Suppose there is a familial polyposis. What is the role of endoscopy? In a FAB patient, what is the role of endoscopy? Just a question. Because you have posed so many questions. Ask one question. Answer now or answer afterwards. You have done endoscopy in this case now.
Yes.
So the suspicion was familial FAB.
Yes.
But he was not looking like that. That's why when you posed the question, the call was silent because it was not looking like a case of FABs. Because some of us have seen FABs.
Yes.
It's not looking like that. I'm asking you, what's the role of endoscopy in FAB cases? Vaginal endoscopy.
FAP cases can have duodenal polyps. So duodenal polyps, periambulary tumors, even jejunal tumors can be there. Jejunal polyps can be there in the familial adenomatous polyposis.
FAB patients can have a lot of polyps in the stomach. These polyps are not adenomatous.
Normally in the literature they said that if there is an adult worm and then we treat it with this thing, then we are going to kill the adult worms, but the eggs we are not able to kill with the drug. So the eggs are going to be there, and the inflammation that has already happened has happened. We cannot regress the inflammation. So after discussing with infectious disease team, we decided not to treat with further doses. We had this doubt that whether in future there is a minuscule risk of malignant transformation or patient developing portal hypertension, and we had a multidisciplinary meeting and we thought that we would give the option to the patient and we gave the option of undergoing left hemicolectomy, but the patient was not very keen on undergoing surgery because the symptoms have resolved and he wants to be under follow-up. For the fear of the portal hypertension or malignancy, or he doesn't.
Can you explain what is calcification? Is it calcification?
I think just after wedding, it is, I don't know, it's just dystrophic calcification after death of the tissues, calcium getting deposited.
Is it more we go back to see if there are new, like the eggs have hatched and new worms have come and so you clear them the second time?
I don't know.
May we ask one question to you?
Yes.
Suppose there is a familial polyposis. The role of endoscopy in a FAB patient. What is the role of endoscopy? Just a question. But you have posed so many questions. Ask one question. Answer now or answer afterwards. You have done endoscopy in this case.
Yes.
So the suspicion was familial FAB.
Yes.
But he was not looking like that. That's why when you posed the question, the hall was silent because it was not looking like a case of FAB. Because some of us have seen FABs.
Yes.
It's not looking like that. I'm asking, what's the role of endoscopy in FAB cases? Vaginal endoscopy.
FAP cases can have duodenal polyps. So, duodenal polyps, periampullary tumors, even jejunal tumors can be there. Jejunal polyps can be there in the familial adenomatous polyposis.
FAB patients can have a lot of polyps in the stomach. These polyps are not adenomatous gland polyps.
Funny gland
And
polyps.
even if the stomach can be studded with polyps, just like the colon, but they are not adenomatous. They are mostly multi-gland polyps and they will not turn into malignancy. So there is no need to do any resection of the stomach even if it's studded with polyps.
For the duodenal polyps, I think there is a Spiegelman classification based on which we do the endoscopic resection and keep the patients on follow-up.
One of these multi-gland polyps in every case in the stomach can be adenomatous. So you need to be vigilant when you do the endoscopy.
Okay.
But most of them, majority are multi-gland polyps. This is why we get this very high.
It is also called bilharziasis. It's a parasitic disease caused by Torrential schistosoma. It is endemic in many tropical countries, mainly in the Middle East, Africa, and South America. So usually schistosomiasis affects liver, intestine, urogenital tract, blood and neurological systems. The gastrointestinal disease is mainly by two species, Mansonia and Japonicum. Acute schistosomiasis usually presents as fever, myalgias, rash, malaise, non-specific abdominal pain, diarrhea, which is also called Katayama fever. But chronic schistosomiasis, anywhere the chronicity, any organ, the development of fibrosis is the hallmark of the disease. So when the liver is involved, the sequelae like portal hypertension, periportal fibrosis is always there. So intestinal schistosomiasis can be asymptomatic. If symptomatic, the most common symptom would be abdominal pain, diarrhea, with or without blood in stools. Some patients can even have constipation. So the colonoscopy findings of intestinal schistosomiasis varies. It can be simple mucosal edema, erosions, ulcerations, hematomas, or rarely polyposis. So the mechanism of polyposis is mainly the granulomatous inflammation surrounding the egg deposits in the intestinal wall. So polyps can be multiple, can be pedunculated, cauliflower appearing like in our case. So range from few in number to numerous. The most common site for the development of the schistosomal polyps is the left-sided colon, because the final habitat of the adult parasite is mostly the inferior mesenteric and pelvic venous plexus. It can develop anywhere throughout the colon, can also develop in the duodenum and gastric regions. So there are quite a few case reports, none from India. from the Middle East and Africa, which shows schistosomal polyps, schistosoma presenting as colonic polyposis. Not much large case series are available on intestinal schistosomiasis, only a few case reports. So diagnosis is mainly by demonstration of eggs in the stool by microscopic examination, colonoscopy plus polyp biopsies is always the standard. So serological tests can be done, like gut associated parasite proteins are there, circulating anodic antigen, circulating cathodic antigen detection in the serum, and serum antibody titers against the schistosomal antigen can also be done. So the final treatment option is praziquantel 40 to 60 mg per kg stat in 2 to 3 divided doses on the same day. Second line of treatment is oxamniquin, which is still in the clinical trials. So intestinal schistosomiasis, medical treatment alone will be sufficient to cure the early stage of the disease like ulcerating granulomas, but it will have no effect on the polyps. So polyps in the intestine ultimately need endoscopic or surgical resection. So take home message, intestinal schistosomiasis, though rare entity, should be kept as a differential in patients with unexplained colonic polyposis who are residents of endemic areas. So the most common presenting symptoms would be lower abdominal pain and diarrhea with or without hematochezia. The standard of diagnosis is to stool microscopic examination and colonoscopy with biopsies. Praziquantel is the treatment of choice for early stage of the disease. Thank you.
Whenever the clinical trial is going on, you can send the patient there. So in their country.
Yes.
After the surface, the clinical trial is going on. You can always suggest and send.
Good evening, everybody. I kept it at the end so that this will have as a negative learning value. This is about a young lady, 34-year-old lady, who presented with long-standing history of dysphagia, 4 years history of dysphagia to liquids more than solids, and she has significant nasal regurgitation of fluids in the night, and chest pain with preserved appetite and weight. So on evaluation, she was actually evaluated around 1 year ago in the same center only. So there manometry showed borderline ARP around 14 like that, with absent peristalsis in all the swallows. And then a barium swallow was done which showed significantly dilated esophagus with resistance of the G junction. So then we repeated the manometry, endoscopy, manometry, and CT again. So endoscopy showed significantly dilated esophagus with the resistance at the G junction. Manometry showed absent esophageal peristalsis with IRP more than 15, median IRP of more than 15. And we did a CT for her which showed significantly dilated esophagus with no pseudoachalasia and CT. So CT was showing air fluid level in the esophagus. The air fluid level. So for her, all the options are explained, and she wanted to undergo a POEM procedure for this type 1 ablation. So posterior approach of POEM was done. There was no candidiasis in the lining of mucosa. So mucosal incision was done 10 centimeters above the G junction, and then submucosal dissection was done. So we reached 2 centimeters below the G junction, tunneling was done, it was uneventful, there was no bleed. And myotomy was started 2 centimeters below the incision site, mucosal incision site, and then we proceeded till the end of the tunnel almost. But the problem was the muscle layer was extremely thin. So actually when we finished the myotomy, so we had a suspicion whether we had really cut all the muscles or not, because there was a rich kind of transverse fibers at the G junction. So I was not sure whether, because I didn't want a recurrence or lack of symptomatic improvement in her. So then I started dissection of the muscle fibers. So layer by layer I started dissecting that thing. So suddenly then massive spurt of bleeding started in that area. So after that I applied the cap tamponade for some time to stop the bleeding. Then waited for a minute and then came back. Then I identified the spot and I tried to apply the quiet grasper to grasp that area. But then bleeding increased after that. So it's like torrential bleeding. So I could not see anything and the entire tunnel was filled with blood. So I had to, because it's an arterial bleed, immediately I came out and shifted and rushed her to cath lab to see what we can do in the cath lab. Because I know that it's not a venous bleed, it's like a spotting arterial bleed. This is a video because it's a long video. I condensed it into 4 minutes time. This is a mucosal incision. We raise a blood with 20 ml of methylene blue diluted in normal saline. Then we made a mucosal incision. This light bleeding was easily controlled with a triangle tip knife. And then we made the entry site. We dissected the edges and we went inside. And then carefully the submucosal dissection was done. Submucosal dissection. So once we done with the submucosal dissection, we started doing myectomy. So at the end of the tunnel, it's around 2 cm below the G junction. So this is the myectomy. So the transverse fibers are very very thin because type 1 achalasia. And usually in type 2 we see a thick bundle of fibers. It's like a layer of coconut like that. It's very very thin. So actually we should have stopped after this. It was actually no spot of blood anywhere in that dissection. So we should have stopped at this area. We are actually seeing, in retrospect when we are seeing the video, we are seeing the longitudinal fibers also. They are in the right place. So this is almost the end of the tunnel. Because we were cutting from below to, because the fibers were very thin, we are cutting like that. So here we started cutting the ridge of fibers, the thick fibers. Then it suddenly started to spot like that. Then the vision is totally gone. So actually I tried to clip on it. We got some vision and I applied the quiet grasper. But then it increased in intensity. Then I had to, because I didn't know what to do, because I have never seen this bleeding I did some 35 poems to 40 poems like that. I saw some minor bleeds which I could easily handle with quiet grasper or something. So at least the thought came that I should shift her to IR. It's not in the zone of surgery thing because she may deteriorate very rapidly. So then the IR, after she got shifted, she started to hypotense in the IR. So getting an access was very difficult, arterial access. They could access from the femoral route, but then the diameter of the arteries were significantly narrowed because of hypotension. We rushed in Paxels, we arrived quickly and tried to access. But then in the angiogram, they could detect a leak from probably one of the main branches from the aorta, probably from direct esophageal branch to the lower esophagus. So then, because the blood was leaking into the tunnel and filling up into the tunnel, so we immediately decided to embolize that vessel. But then because the IR hooking probe, it was not exactly going into that area. It was just leaking and patient is rapidly deteriorating. So we had to resort to doing some rapid intervention to stop the bleeding from that area. So cardiologist was available in the same cath lab. So they decided to put an aortic stent graft to seal off that area. So they immediately tried to insert an aortic stent graft, but then because of the caliber of the arteries were completely spastic, they could not go from the femoral axis. Because the diameter of the aortic stent graft is significant, it has to have a normal caliber of arteries to pass in the stent. So then they decided to get another access from subclavian route. Then it took a lot of time. They could not get access and they had to call surgeon again. Cardiologist had to punch it 4 or 5 times, then get some access. So then putting a stent was very difficult. So through the subclavian and from the femoral route, they could do something and rendezvous kind of thing, and then they could place a stent ultimately. After the stent placement, immediately the bleeding stopped, and we did a check angiogram after that to see whether we have blocked any other circulation to collateral circulation, whether we blocked the vertebral, whether it's fortunately all the vessels were intact. The plexus was intact. So then she was admitted in ICU after that, intubated and admitted in ICU. So fortunately she did not have any bleeding after that. The next day morning we did a CT. This is the aortic stent graft. So CT done next day morning shows IV contrast, there is no leak from the site. There is a 6 to 7 centimeter hematoma in the region of the distal tunnel. So she is stable, she was extubated the next day. So then 3 days we kept her NBM and IV antibiotics and supported treatment. And after 3 days I placed an NJ tube. So I tried to go into the tunnel just to see what's happening. So I could see a big clot inside without any active blood. So I didn't touch anything in that area. So I didn't close the mucosal incision. Because if you close the mucosal incision, it will become an abscess like that in the inside. So then I left the incision and kept an NJ tube and observed for 5 more days in the hospital. Then we discharged her to come back after 2 weeks time to reassess. So she came back 2 weeks later and she is lying down on the bed for assessment. Then she started vomiting at the time. Started vomiting hematemesis at that in front of me. Before the procedure started, she is having, I thought some altered blood in the tunnel is coming out. And she is having the 5th time, 6th time, 7th time she is having bleeding. Then I had to rush to CT and see what's happening. So in the CT contrast, there is a contrast leak within the hematoma. So there is a branch of probably left gastric artery or something within the hematoma which is eroded and is bleeding from that area. So then immediately we rushed her to cath lab. She was fortunately hemodynamically stable at that time. So we rushed to IR and did angiogram again. This time access was very difficult because she is hemodynamically stable. So there was a leak from the left gastric arterial branch, one of the branch of left gastric artery. So this area. It's a very faint blush is there. So this area, embolizing this area is extremely difficult. Fortunately, we had Dr. Suresh who was joined in Apollo. So one intervention he was trying for a lot of time. He could not get access to the super selective access to that area. Then Suresh did super selective glue and coil embolization and blocked that vessel. With that, the blushing stopped completely. So there is no leak of contrast. Subsequent CT then next day showed actually resolution of 3 centimeters reduction size of hematoma within the tunnel. So we had continued antibiotics. We have this time we had kept her for 10 days because I wanted to because my worry at this point is whether she'll rebleed. That hematoma is eroding adjacent vessels or what's happening, whether it's some infection within the hematoma which is causing rupture of vessels. So rebleed and development of an abscess. These two are the problems at that time. So we continued on high antibiotics and kept an observation for some time. We were monitoring CRPs. Fortunately, she didn't develop fever or any hemodynamic problems at any time. She had small volumes of altered blood in the vomitus, but that looked like clots which are gradually resolving. So we can just observe without doing any further CTs or endoscopies. Then after 2 weeks, bleeding episode slowly subsided. Then a scopy was done at this point in time, after 2 weeks after the second bleed. Then the scopy showed a mucosal defect. This is probably because the area where the major bleed happened, the mucosal flap had got necrosed. So it's fortunately it was a very small defect, around 8 to 10 mm in diameter. I injected contrast within that small opening. So it was not extravasating into the outside the lumen. So it's just like a diverticulum kind of thing. So I observed with 2 more weeks of NJ tube feedings and saw her after that. So after that, the entire area was completely healed and there was no problem. The mucosal tunnel, mucosal opening sites got completely closed and there was no resistance fortunately at the G junction. So the atlasia is cured and there was no problem with the. We repeated the CT again, which showed complete resolution of the hematoma. So at this point in time, the relatives were burnt out at that time. So their question, the husband's question was, so who will take care of this stent problem in the future? It's a valid point, but I said, she has to be on dual antiplatelets for 6 months and then single antiplatelet for life. Because aortic stent actually doesn't get blocked easily. Because of the high flow, it usually, even if you don't give antiplatelets also nothing will happen. But because of the brachial access, that access needed to be closed with another metal stent. That caliber can be blocked if antiplatelets are stopped. So that was the future implication of this one. So in because I couldn't find any literature in this one, because this problem is kind of we have probably went beyond the territory of the dissection. So what I presumed was I was discussing constantly with Dr. Mohan Ramchandani, Dr. Sudipto in Velu. With their inputs we were constantly guided by Dr. Vikas Singla. So Vikas Singla actually gave some insights about what might have happened. So he was saying that probably you must have cut some diaphragmatic fibers, thinking that they were lower esophageal sphincter fibers. So that has caused some arterial injury below the diaphragm. That was one possibility. So in the case studies, probably all the literature in the poem is not reported. That's one. When I was studying about the things, all the major complications are not there in the search. So some minor bleeding, 2% bleeding, 1% of infection, very low complication risk is there. But when you ask somebody, when you personally, they may tell that a lot of profuse bleeding can happen, a lot of complications can happen like that. So the literature search, so the bleeding during poem is an important problem. That is the scary thing in the poem. So bleeding most commonly happens during at the G junction, where big caliber vessels can be there. Arterial bleeds can also be there. So the very careful dissection, fiber dissection at G junction should be done. So usually most of the bleeds are fortunately mild in nature. They can be controlled with scope tamponade, coagrasper, or sometimes even with the tip of the LB knife or TT knife only. If the caliber is less than the tip of the knife, we can just coagulate them directly. So in rare cases where the bleeding is challenging, some people have used tamponade with CRE balloon also within the tunnel to stop bleeding, and then they can get some vision and block the vessel. I didn't find any IR based procedures for poem bleeds in the literature search. So some bleeds can happen after 3 to 4 days, delayed bleeds. So what we do with delayed bleeding is we do a CT at that time to see whether there is any contrast exaggeration. There is an arterial bleed or venous bleed. The arterial bleed we try to do IR and block the vessel. If it's a venous bleed, then we probably have to re-explore. We have to open the tunnel, go inside, then do something. Or if the hematoma is stabilized and the patient is stable, then we can observe and see. Give rest with an NJ feed and wait and see with antibiotics. So the lessons learned in this entire exercise is of 1.5 months time. Complications can be very devastating and deadly in third space procedures. So multiple operators better to be avoided unless one is very expert in seeing poem or doing procedures. Unless one has very vast experience, you should not decide to train other people or do something. So then maintaining the plane between the circular and longitudinal walls is key for safe procedure. The initial cut, we have to decide what is our plane. Then we should proceed in the same plane. We should not keep doing cutting the fiber after doing dissection. then a pre-procedure CT, especially in elderly people, gives valuable information for anatomy of the vessels around that thing, to get an idea. And fortunately, the mucosal defects in POEM need not be closed in all the cases, several cases. If we close the defect, then actually we are compromising the vascular supply. Just leave it with an NJ tube and wait for some time. Even big defects also close off. And infection of the tunnel also is fortunately very rare. Developing sepsis, septic complications because of hematomas or something is very rare. And most of them with IV antibiotics alone, they can be managed. She has cleared herself all the hematoma. We didn't have to do anything endoscopically.
Initial CT you had was it light CT?
Initial CT was an oral contrast. Because I saw another elderly guy came after that, who was actually advised to just maintain with calcium channel blockers. He's 80 years old, but he looks like 50 years old guy. So he wanted to undergo POEM procedure. So after this, I got a bit of a feeling, and I did a CT for him. The aorta is like this, and the esophagus like this. So, I mean, it's a sigmoid esophagus. Then I said, I do Botox for you, not more than that thing. Then he said he is done calcium channel blockers. She's actually a staff in our hospital. That's another big, positive and negative thing for me. Positive thing is that the bills are all waived off. Negative thing is that all the staff are behind my life. So when I'm waiting in the IR, some 100 people are waiting outside. So from once a complication happens, after that, whichever doctor deals with it, it's your responsibility. You are responsible for everything that happens to the patient after that. So short term, long term, everything. You have to own the patient, that's all.
What is the position of the surgeon in this case?
So actually, sir.
This patient seems to be having a sigmoid esophagus. So would you have decided for a surgery in the initial step itself rather than going for a POEM?
So actually, it's not a sigmoid. It's dilated esophagus, but there is no S-shaped component. So actually, when she was bleeding, and I was, when we were in soup, I was thinking whether what should I do? Whether I should rush her to operating theatre or whether I should rush to cath lab. Only thing is that my instinct was, because it's an arterial bleed, it didn't look like a venous bleed. So I decided immediately to do IR and do something. So in fact, when the IR, I called CT surgery, one of the persons from CT surgery. So they were actually very not keen to take her for surgery because of hypotension. And actually, when she was in hypotension, they were also giving NTG to dilate the arteries so they can get some access. So it's like blood is going on, NTG is going on, inotropic support is going on.
I think 2 points to learn from this one. So from the video, what I observed is, because we are going to go full thickness myotomy, we are in the mediastinum technically, isn't it? So position of the scope or accessories, even assistants, if they move the accessory forward than you thought, can have a deeper burn. So I think slightly undercutting is much safer than overdoing in the G junction area. That's one point. Second one I noticed in the video is going from above down. I think G junction, I think throughout the myotomy, better to always come from below into the lumen, because we don't know where what is lying next to it. Is it astragalus vein, vagus, or abnormal aorta or aneurysmal aorta, whatever it can be. It's always better to have a vision where the knife is coming up. I think those are the 2 learning points.
So you mean to say from the lower end of tunnel upwards?
Yeah. So into the lumen, so that we will know the under vision we will be cutting all the time. So it's inadvertent injuries will be less.
Retrospectively, when I saw the complete video, it's looked like we are out of the territory.
Yeah.
It's like
went beyond into.
But then because we are not surgeons, we don't know how the diaphragm looks like, how this fiber looks like. We actually don't go during routine POEM. So only when it's exposed, we are in a doubt whether this is LES muscle or diaphragm, what's happening there. We don't know how it looks like. Unless in this case, retrospectively I'm wise, but now.
I think probably I can say, I think we should compliment your quick thinking, and as you have rightly mentioned, advanced procedures do carry their own unique, bizarre complications, but that was a good, quick thinking from your side. But the other thing, probably I can add from my little experience is that, I think partial myectomy, once you have gained enough experience, is the right way to go. Never do a total myectomy, because when you're trying to do a total myectomy, you blindly push your whatever knife you have well beyond the longitudinal muscle. So that's where you enter the space beyond your idea.
So one problem is, Rakesh, what happens is that initially we are very sure that we are in between the longitudinal circular. Sometimes after this burning, it becomes like a single layer. This longitudinal gets played here.
That usually happens once you start going to the gastric side. So what you need to do is that, try not to go deep. And in fact, I think this last month, Zahir's paper has also come up where he has compared to total myectomy with partial. And they are saying that partial is probably much more effective. Because once you start doing total myectomy, you start dipping, your scope start dipping into the posterior mediastinum. That's how you come in close contact with these larger structures. The other issue was that I think the second thought of trying to cut on your left side was probably the undoing thing. Once you have gone into the gastric side, you should have probably stopped there.
Actually, we should have stopped well ahead of all these things. That whatever ridge we are seeing of muscle, transverse muscle, that we should have understood that doesn't belong to our territory.
Yeah, Dr. Zahir, I think what is your take on this?
I would like to compliment you that you shared your experience with us, because this is something that you have to learn without doing it, right? So I think not many things to add. I think Rakesh has already added few points. Such a bleed, unless we really see the video in real time, it's very difficult to say what could have been done. So what was the intensity of bleed? Posteriorly, always the blood pools there, so it's very easy to miss the bleeding site, right? And it's not difficult to panic. Like, we panic always. Like, even after doing so many poems, we still panic. Like, when some things don't go in the right direction. But what actually happened is very difficult to see from that short clip. That it was a spurt, and then what happened next was very difficult to comprehend. What you did at that time was absolutely fine, because you did in the interest of patient and saved the patient at the end. So from my side, few comments that type 1 achalasia, always go for a very short myectomy. Never go for a long term. Why 10 centimeter above? Why to fatigue yourself for a dilated dead esophagus? You don't need to cut that much muscle. It's a wide esophagus. You can see that the muscle is really thin. So you're not really doing anything. You're not helping out the patient by cutting such a thin muscle. This is one. Second is, it's not uncommon to see the diaphragmatic muscle which looks dark red in contrast to the muscle fibers which are like light pink or that color. So it's easy to say that probably I didn't cut enough and patient may not get relief. Patient does not get relief, he can be managed, no issues at all. But if you are unsure of what lies beneath, it's always. I have cut the diaphragmatic crura partially, so then I realized probably I was behind. There's no difference between full thickness and this. Full thickness, the only difference is sometimes your procedure is faster because you don't need to maintain those planes, right? And longitudinal at the end, anyhow they split, so no difference between two. So short myectomy, and it's always the left gastric artery branches which bleed when you go beyond the GE junction. It's almost 100% it's left gastric artery branch. So especially at 2 centimeter beyond GE junction, you need to be especially careful when you are extending your myotomy beyond 2 centimeters. So now we usually stop at 2 centimeters because that particular branch comes especially at or beyond 2 centimeters. So that's always what we tell those who are learning now, that don't go beyond 2 centimeters. If you go, then always visualize that thick blood vessel which sometimes comes, and we feel that probably we won't be able to coagulate that vessel even with a coab grasper, so we stop behind that vessel.
Very valuable point.
Thank you.
So when the problem in this case is, it's exactly like LES. It's like a projecting thing, and it didn't appear different to me. But I was relentless in cutting that area. But I was not getting under it. That's one area where I should have stopped. So usually when LES is there, you will get below it. There will be a mediastinal tissue in the, there is completely muscle fibers is all around. I am not able to get below it.
Second is one more thing, that spray coagulation or the monopolar modes, spray coag, it's like 2500 volts. So it's like now we are moving to less and less. I think Rakesh is also moving to less powerful modes, so that collateral damage is less. So even if you hit something by mistake, by chance, the damage is not so severe. So we are moving to endocut modes with less power, less voltage, so that the surrounding damage is as little as possible.
Sometimes what happens is that in that area below the 2 cm below G junction, some vessel starts bleeding in that area. So after that we did 5-6 poems after that. So one reader was there which I could manage with coag Gastro. Then my scare is when I am doing myotomy, I am very scared to cut in that area. Actually when I did cut, it started bleeding again. The same extent from the vessel. Again I stopped the bleeding. But then I mean, do we stop?
I think that will stay for another few cases. It's a recent happening. So this happens with everybody. I think it's good to share. It's good to share.
Till the end of the tunnel, or can we afford to just stop just below G junction if some massive good bleeder is there?
I think there are two perforators which always comes. So they need to be coagulated. They can be coagulated. It's safe. But beyond that, it's towards the what you say peritoneal side that you see that particular bleeder, which is a very thick vessel. So I think that that has been described by Japanese as well. That and they have described. PGI group has described. It's not yet published, but angioembolization. What you had faced, I think few groups have already faced it, and the same consequences, I guess. So angioembolization has been done, but sometimes it's not very useful. So these things happen rarely, but you did a fantastic job. Thank you. Speedboat, I think we can do that. So now ultra slim one, which is compatible with 2.8 mm channel, is going to be released in April. It's going to come in India. I think it's available in Europe and US. So I think with that, the collateral damage may be less, but then it requires a lot of maneuvering from the technicians. The technicians never like speedboat because they have to constantly move the direction of the speedboat. But I think it's going to play at least some role.
Thank you, Team Apollo, for sharing interesting cases, and thank you, Dr. Bharat, for sharing your night with us. Let's conclude with this and let's gather for dinner. Thank you.
Sir,